Annette Stark is a 78-year-old female who presented today with trouble breathing over the last 24 hours. She has a past medical history of COPD and arthritis. Per the patient, she was changing a light bulb outside by her driveway when it onset. She does not know what happened that made it worse. She had tried her PRN albuterol inhaler with no relief and with no other treatments at home. Nothing seems to make it worse, but she feels like it is progressing and getting worse over time. She is hypoxic on exam and going to be admitted to the hospital. She takes albuterol as needed, Lortab, naproxen, and Singulair. She is allergic to nothing. She was hospitalized 3 months ago for a COPD exacerbation. Her mother died of COPD and also had hypertension, and her father had diabetes type 2. She drinks 1 glass of wine weekly. She smokes 1 pack per day of cigarettes. She denies illicit drug use, and she is not currently sexually active. Her review of systems is negative except as mentioned, positive for fatigue, positive for cough and shortness of breath. She's positive for a postnasal drip and positive for anxiety. Everything else is deferred. Her weight is 130 pounds. She's 5'6". She's 99 degrees Fahrenheit. Her pulse is 70. Her blood pressure is 140/70. Respiratory rate is 20, and her SpO2 is 88% on room air. For her physical exam, everything was within normal limits, except for respirations were rapid, shallow, and regular rhythm. Her lungs were cleared auscultation. For her lab work, I ordered a CBC, CMP, lactate, troponin, which were all within normal limits and non-revealing. I got a chest x-ray, which showed bilateral hyperinflated lungs with fine effusions bilaterally, no pneumothorax, consolidative mass, and her cardiac outline was within normal limits without pulmonary edema. Her EKG showed a normal sinus rhythm with no acute ST changes, no T-wave inversions. My 3 differential diagnoses are COPD exacerbation, resultant pulmonary embolism, and pneumonia, unspecified viral versus bacterial. I believe that the likely etiology of her respiratory failure is environmental exposure, as she was outside when this happened. I would like to admit her to an observation bed, medical surge, whatever that hospital has. Because she was hypoxic on arrival, I placed her on 2 liters nasal cannula. Given that she has a history of COPD, I want to wean her oxygen as tolerated to a goal saturation of 88 to 92%. We're going to start her on prednisone, 40 milligrams PO daily for 1 week per the gold standards. I've started her on inhaled budesonide twice a day with albuterol, ipratropium, Q6 hours, and as needed, Q4. I'm going to get a CTA PE protocol to rule out pulmonary embolism, especially in a patient with COPD who can have non-symptomatic subsegmental PEs. I was unable to get a D-dimer, but her Wells score is 3, so I feel like it is worthy to move forward with obtaining the CTA. Due to her fever, we'll empirically cover for community-acquired pneumonia with ceftriaxone 2 grams, IV piggyback daily for 5 days. She has no history of multi-drug resistant organisms, so ceftriaxone should be broad enough, and I'll de-escalate and make final decisions with a respiratory culture and procalcitonin in the morning and de-escalate the antibiotics appropriately. The patient will need a walk test prior to discharge to obtain her oxygen need, and while she is in the hospital, I'm going to keep her on 40 milligrams of enoxaparin subcutaneous daily for VTE prophylaxis, assuming that her CTA PE does not come back positive and require full dose anticoagulation. Health promotion is the biggest piece for this young lady who was counseled on smoking cessation and the need to quit to slow the progression of her COPD, as the smoking will only progress her illness to more advanced stages. The patient does not currently follow with a pulmonologist, so I will refer her for outpatient follow-up and ask the social work case manager to help her get established sooner rather than later. Thank you.